Hello, welcome everyone to the Person-Centred Complex Care session of ARCFEST. This is the last main session of the day. And also got Pallavi Deshpande, our theme manager, on the call, and Jenny Downing, our research fellow, and Steph Tomlinson, our public co-lead. And we also may have Alan Griffiths joining us as well, who's our other PA co-lead. So it's a game of two halves. We've prepared some talks to outline some of the work of the theme and also reflect on the health inequalities, which has been very much a theme running through the day, and then the second half we've devoted to extending the conversation around the integration and coordination of care, and our hope is that we'll get some ideas from you and a kind of an update of projects and the service changes that are being implemented or thought about among the partners, because we've identified integration of complex and continuity of care as a really important area to be working in, but we've really struggled so far to identify the specific things that we want to do, and I've reached a point where I think it's really important that we understand that the sorts of things that the partners are wanting to get up and running, as well as research projects that are planned and are maybe ongoing and have a bit of a focus on integration and coordination of care. So I'm going to hand over to our first speaker, which is a recorded session. So this is a session recorded by Rose Johnson, who's going to tell us about her peer online forum, which is a project that's come through the prioritization process through ARC and is getting up and running. So I don't know if we're able to present Rose's presentation.
Hi, we are a group of researchers, clinicians and service users led by Lancaster University who are interested in understanding how peer support works. Specifically, we are interested in how peer online forums work within mental health, particularly why some forums work better than others and why some people find peer online forums helpful and others do not. We have received funding from the National Institute of Health Research to conduct a realist evaluation of online mental health communities to improve policy and practice. The aim of the study is to improve the uptake, safety and usefulness of online mental health communities, with the study set to last approximately 34 months. So why are we interested in peer online forums? Peer online forums are of interest to us as a result of the pandemic. The pandemic has seen and continues to see an increase in mental health issues, which has meant that traditional mental health services have become inundated with individuals requiring support. Consequently, as a result of the limited support, people have started to look online to find the support, with one method of support being offered as peer online forums. Online forums offer the chance to share, discuss, solicit information and find support related to mental health needs. They allow individuals to talk to a range of people with relevant expertise and experience within mental health. Additionally, they allow individuals to practice disclosing information about their mental health to overcome issues such as self-stigma. Additionally, many forums are available 24/7, so can provide support whenever it may be needed. Online forums can provide a way of trying to reduce inequities within mental health care and services. For example, they can help to try and overcome previous issues with geographical location of services, as peer online forums can be accessed from anywhere, provided there is internet. Additionally, it allows access to some form of mental health support for those who are typically underserved by mental health services, as anyone can access these online forums. Additionally, it can help to overcome cultural and language barriers that can be seen in traditional services, as forums can be designed with specific cultures in mind and can be run in different languages. However, with that being said, peer online forums are not without their difficulties. For example, the information posted on forums can be misleading, inaccurate, harmful, and triggering. Furthermore, hearing the experiences of others may exacerbate low mood in users, increase risk of harm, generate anxiety, and unrealistic expectations of one's own conditions. Members may also worry about how their data is being used within the forum, especially concerns around advertising and data exploitation by forums for funding. Additionally, people experiencing mental distress are particularly vulnerable, and exposure to unsafe peer online forums may have serious negative impacts on their mental health. There are also negative impact for those who moderate the forums, as they may start to feel responsible for their users, and if they have received inadequate training or supervision, the exposure to the content on mental health forums may be distressing and affect their own mental health. Therefore, this study wants to answer three main research questions. What are the impacts of using online mental health communities for people experiencing mental health difficulties? How, why, and in what context, and for whom are these impacts generated? Secondly, what are the roles of community moderators and how do they impact online health communities? And how can evidence-based theories of online mental health communities be used to inform best practice guidance and support? So, as mentioned previously, a realist evaluation was decided on as the chosen methodology to really understand how and why peer online forums work and don't work in a variety of settings. The study has been split up into three work streams. Workstream 1 focuses on theory building and hypothesis generation. So within this workstream, we will help try to construct initial program theories, which are statements pertaining to how and why peer online forums supposedly work. To develop these, researchers will search the literature as well as interviewing relevant stakeholders within peer online forums. In Workstream 2, we'll be looking at refining and testing these initial program theories. This will involve community members completing surveys to assess the impact of peer online forums. There will also be qualitative interviews with community members, moderators, hosts, and commissioners about their perceptions of peer online forums and why they work and don't work. Additionally, corpus-based discourse analysis and natural language processing of community posts will occur to test the hypothesized mechanisms of the program theories. Workstream 3 will be concerned with the outputs, which is a range of tools and implementation strategies. Throughout the three work streams, there will be a PPI host and impact groups who will be consulted. They will be consulted on things such as potential mechanisms, prioritization of theories, and the dissemination of the research findings. So the outputs, the idea is for the PPI groups, the host groups, and the impact groups, and the researchers to co-design best practice tools and support for people involved in commissioning, hosting, moderating, or using online mental health forums. For example, we want to create knowledge videos on mental health communities and how they work to help increase knowledge of potential users and commissioners. E-learning curricula for moderators is also something that we want to develop to help train and support these moderators in mental health communities. Additionally, best practice design principles are another output to try to minimize harm and maximize benefits within the design of a forum. Finally, we want to try and make sure that these outputs are disseminated throughout the NHS and relevant third sector groups. So the team that will be involved in this project come from a range of different backgrounds, from mental health related research, computer science and linguistics, just to name a few. So what we are looking for, as previously mentioned, this is a funded study by the National Institute for Health Research and is going to be conducted across the UK, and we are looking for partners to work with us. We're keen to hear from you if you meet the following criteria. You are a health and social care related organisation, focused on improving mental health and wellbeing, UK based, aimed at adults 16+, and have either set up, are planning to set up, or previously offered an online mental health forum. If you know of any charities, forums, or organisations that would like to get involved, please contact Professor Fiona Lovin at the email mentioned on the slide. Also, if you are or were a moderator, user, or are doing relevant research in this area, please don't hesitate to get in contact with us. Thank you.
Okay, that's really interesting. Wonder whether there's anybody who wants to raise any issues or discuss any elements that they've heard there. It's interesting coming out of the EPIC meeting into this, and we've just been discussing about sort of place-based support, and I wonder whether Paula or Steph want to comment or think about the bit of juxtaposition there, really.
I think I was just going to say, obviously I'm going to be touting for the Community Research and Engagement Network, but I do think, and I have spoken to Fiona about this project very early on, is something about we only know what we know. You know, even when we do, you know, the literature reviews or whatever, there will be what we call it the grey literature, but the grey place-based initiatives that are going on, and maybe as I've suggested in my presentation, using that current network for a bit of horizon scanning, because we do only know what we know, and there might be interventions that are already happening that we've not found out about, and they could be supportive of that peer network model, peer mentor model. Yeah, so absolutely, I was just going to put in the chat that, yeah, I think a few conversations to be had with these emerging projects that all sound relevant and pertinent to what we're trying to aspire to do within that current network.
Thanks, Paula.
Can I just tap in, Tony? I think through COVID, a lot of online forums were set up, which supported several networks of community-based support networks around mental health, around mindfulness, and around peer support, peer suicide prevention, and things like that. And there's a general wider Northwest Coast network that I can send the information through, and that's got lots of really good links that we're linking locally as a community, but it's wide and far. And that's a WhatsApp group that's been set up through a voluntary sector organisation, which is really, really important because it's got some really key partners in it that offer sort of training opportunities, network connections, and also open doors for other partners to work together closely on equitable based places, really, for people who are struggling through peer lack of support or lack of networks that were there pre-COVID, that are not still in the public domain. The more a phone call or a digital platform to be sort of supported with. Thanks,
Steph. It'd be important to feed this back, and perhaps link you up with Rose and Fiona. And there's also a comment in the chat around kind of digital poverty, it's kind of health inequalities, people not being able to access these kind of forums, if I'm following what's going in the chat. Okay, so that's really helpful. I'm going to move us on. So our next chat is a live chat from Steph. Delighted to invite Steph Tomlinson to give us a bit of a theme update from her perspective, really, as to how things are progressing. So I think, Pallavi, you've got your finger on the slide forward button. So Steph, over to you.
Thank you, Tony. Welcome everybody. Person-centered complex care. The name itself is complex, I think. The next slide, please. We've got sub-themes: the continuity of care, digital healthcare, and multimorbidity. I think through COVID, I think these platforms have been very much changed through, especially digital healthcare. Lots of people with person-centered sort of complex care needs have undertaken appointments via digital health platforms or telephone consultations, and even GP practices have often gone through the same process to assess and support people with complex needs to be able to get the right support locally. Some still do offer face-to-face, but very limited. Multimorbidity is very in the headlines at the moment, especially around the connections with other services they need to access. There's a big thing locally at the moment with access to GP practices and GP appointments, and waiting times in hospital A&Es and things like that. So there's a great deal of pressure at this very present time with this new variant for COVID, and trying to support people with various complex needs locally, and also within hospital or within digital platforms and settings. I think continuity of care for me is it covers several avenues really. It covers people from things like addiction, to me is important to me at grassroots really, because if people have got addictions and they don't want to engage, this puts additional pressure on families. And when families try to access platforms of support, whether it be substance misuse companies or mental health crisis teams or police or GPs, they can offer and support, but the person with the addiction needs to hold the hand up. Holds the hand up directly. And this puts additional pressure on families, specifically with a person who's got an addiction. Addiction could be drugs, alcohol, gambling, mental health. Some people have got severe aspects of mental health within the community that people find difficult to cope with, but unless there's in-house support for them, or they are willing to engage, this is a discontinuity of care unless that person with the support needs will engage. And I think through COVID, I think the services have been very limited, and the pressure on in-house services like social landlords, crisis teams has been very, very limited because of the sheer number and the sheer volume of people coming who have that need. People coming off the streets and putting into social, in sort of the Whitechapel Centre, reintegrated into social housing or into council housing, but with high needs, and the support that they offered is always either only on digital platforms, either Zoom or Teams. Sometimes this doesn't work. Some people don't want to integrate at all with a camera. They want to see someone face to face, and that is the big barrier for me. I think digital healthcare moving forward, I think still offers slightly, to me, my experience, I think it's the way forward, but I think it also offers a little bit of a disconnect to people who have digital poverty. Digital poverty is huge, and unless there's community IT support networks, or there's a lending scheme for digital devices to be offered, that's where people will fall and not attend appointments because they don't know how to turn these devices on. They lack the understanding of what the devices are, and they will often speak through a second person to sort of ask the question what the doctor's asking them, which doesn't really tell the true picture. So I think all of us have got to sort of be ready for the changes moving forward, but digital healthcare platforms also need to connect with each other, whether it be one service to another or one area to another, to ensure that the continuity of care is met and everyone communicates with each other. Next slide, please. I mean, our projects, our total projects, I'm a bit lost at this, if I'm honest. I need some support, sorry. Jenny, help.
Right, no worries. But this is just a brief overview of the types of projects that we've got. So we're looking at our numbers of total projects, around 56. Externally funded, we've got 8 externally funded projects, 9 PhD studentships in the theme, and 5 internships. They're really small numbers, them. So I'm not surprised you can't see them easily, Steph.
Thank you, Jenny. You're a
No
savior.
worries.
Next slide, please. Up to date, total funding is 6.4 million for external grants. We've had 22 papers published and 10 submitted in preparation for publication. Next slide, please. Health equality, how do you address this? I think health inequality is quite is huge within communities within the Northwest Coast area and beyond, I would say. I think health equity is and can be addressed by working with each other, working in a more connected way. I'm totally off on a tangent here that I'm not supposed to be on. I'm making a total wally of myself. Jenny, help me again, please.
You're not making a wally of yourself, don't worry at all, Steph. Really good points. Just some examples of how we address health equity in the theme is we're looking at advertising for our public advisors to inform our health inequalities assessment toolkit form. And as you've seen from earlier today, that's firmly in development, and lots of our public advisors have been working with the team on developing the next version of that. We make sure that health inequalities have been addressed in all the projects that are presented to our theme by ensuring that the teams have completed the HIAT form and are working with public advisors as well. Back over to you, Steph.
Thank you. Next slide, please.
So that's actually the end of our slide.
So, sorry, I was just going to add about health inequalities. I think health inequalities are very in the news at the moment because of lack of services. Some services have integrated to make one bigger service. Some services have been put on a back burner, especially people who live in deprived areas. The inequalities within communities and the inequalities with services just disbanding because of lack of funding or complexity of needs of the people. I think some avenues we've talked about, like digital inequality, also comes hand in hand with health inequality. If you've got poor health and you need to do a shop online, or you need to access services online, or book a GP practice appointment online, because a lot of GP practices are offering you the online service to book appointments, to get prescriptions directly to your chemist. And again, it goes to digital training or digital knowledge. And it can be a big health inequality. I know in the area I live, Knowsley, health inequality is massive. There's not enough free IT support. There's not enough free digital platforms available for people to pop in or to access. And GP practices are often, I've got a thing on the wall where you can just put your date of birth in, and that makes sure that you're noted that you've attended for the appointment. They're not even you can't access them anymore, and it's the continuous rebound and the amount of people that are needing to access services at the moment that often people will give up after several tries to get a DP practice appointment, or just to link in with a support worker, or link in with a appointment within a hospital setting, or with some form of other care that they need, because it's either there's a waiting list, there's a waiting time on the phone, and they're on benefits. So that £10 credit that they've got on their phone for 2 weeks, if they wait for 20 minutes to get in touch with their occupational therapist on the phone, they've got no credit for the rest of the week. So it's difficult. Health inequalities cover huge and vast and varied areas that have an impact directly on the people with health problems. I think COVID has changed and brought plans forward for GP practices and healthcare settings. Say 2 years, these were plans that they wanted to integrate slowly. Within 2 years, COVID has brought that forward for them. And a lot of people found this very difficult to get their head round, especially if they just can't go and meet up with their friends in the GP practice and spend an hour there chatting with Dolly from number 3. So it's difficult. This has an impact on wider family and caregivers as well, especially for respite practice and social care packages and things. That's it really. I think complex care and health inequalities can go hand in hand. If there's not, support is always going to be needed, but there's also changes about in the respect of digital accessibility, digital poverty, and health poverty in the respect of being able to access this, especially if you're housebound, or if you're relying on a carer 4 times a day. How do you get access to these? Carers haven't got time. They've got a 15-minute, half an hour slot to prepare a meal or to support you with medication, and then you need to make that appointment, or you need to get that prescription, and you can only access it on a digital format. If people are going without missed appointments, are going missing appointments, and the doctors are quite good to show you how many people haven't pitched up for an appointment this month. Some of it is probably because they can't access via digital platforms if available because of digital poverty. That's me done. Thank you very much.
Steph, that was fantastic.
Sorry, I was a bit of I blubbled a little bit there, but thank you, Jenny.
Oh, you're very welcome.
Great teamwork, and a really, gave really important context to the problems that we really need to fix. There's some helpful comments in the chat. Language is important, and multimorbidity is very medical speak, and using terms that people own is clearly the right direction of travel. Comments about people's concerns about safety of using online forums. Are they confident there? I guess that's confidence in confidentiality, amongst other things. Yeah, okay, but that's great discussion. I'm just trying to work out whether there's anybody with their hand up. I've realised I don't know if there is a hand up option in this Zoom meeting. Okay, I've now got the chat. I've now got the participants open, so I will be able to see if anybody puts their hand up. So if you do want to contribute, do please put your hand up. I think what I'm going to do now is move us on to the next part of the agenda, which is another recorded talk, and it's going to give perspectives from an investigator and a public advisor about using the HIAT, continuing with using the health inequalities assessment tool and as it's evolving over time. So if we could show the next video, that would be fab.
I'm Edward Chancellor, a senior clinical lecturer in primary care and a GP. Together with a team of colleagues, we consider a study to reduce the overtreatment of hypertension in people with frailty who are 80 years and older. We want to do the study as the benefits of antihypertensive treatment in this group of people are less established, and they were often excluded from clinical trials of antihypertensive medications. Due to frail health, they are more likely to experience side effects such as falls. As a result, risks of antihypertensive treatment may outweigh the benefits. However, the approaches to possible deprescribing are not well established, leading to possible negative attitudes among patients and uncertainty in clinicians. And we want to address this by developing an intervention to reduce overtreatment of antihypertensive drugs involving patients, their carers, and their clinicians to make a shared decision on the best treatment options. Thank you.
Hello, my name is Hilary Garrett. I came to be public advisor for ARC North West Coast when I was the primary carer for my mum and my auntie as they became frail and infirm with old age. The sisters both had cardiovascular disease as part of their long-term complex health conditions. On this project, I have been fortunate to work alongside Saika Ahmed, an experienced public advisor who brings a more culturally enriched insight to the team, along with her caring experiences for her own family.
Support from public advisors is crucial for our project, and I have had an excellent experience from both public advisors and the ARC team. The public advisors have been very enthusiastic, friendly, and at the same time capable of delivering the views and experiences of those for whom the study is being designed. They were able to accommodate several meetings and volunteered to work together throughout the study development. The discussions were further complemented by reading a proposal draft and providing feedback. I would like to express my particular gratitude to Hilary Garrett and Saika Ahmed. Thank you.
The process of revisiting the experiences of caring for my mother during a period when she was being overprescribed drugs to lower her blood pressure feels like my mum has found a voice in the project. Being able to point out the inequity that being old and frail brings and how this can affect the mechanics of the research, I believe was useful. For me, it feels like my mum and Auntie Margaret and all those people like them are being put centre stage in this research.
Comments and advice from public advisors have been extremely helpful. We received strong support for the ideas of the study, but at the same time, discussions with the public advisors have helped to identify possible weaknesses of the proposed study design. This was partly by helping to understand how the proposed intervention for optimization of antihypertensive treatment can be viewed from the receiver perspective. As clinicians, we can be easily biased by our own agenda, and understanding the views of our clients is extremely important. Additionally, the public advisors pointed out possible problems taking part in the study due to health inequalities, such as difficulty measuring blood pressure by some elderly frail people, even if the blood pressure devices were provided. We will consider these during the further planning of the study. Thank you.
Working with Edward and the project team has been very positive. I felt I was able to offer insight into the inequity felt by older people and their carers when dealing with health professionals. I was able to point out the possible physical and other difficulties that might arise for people in taking part in the research. This has emerged as an area to be further explored and addressed.
Okay, that ended a little sooner than I was anticipating, but that was a great interaction. I'm aware that we've got Edward and Hilary on at the meeting as well. Is there anything that either of you want to add, having seen that and reflected any further, or are there any questions that anybody's got for them? And how's the project progressing?
Actually, from my side, that was a great experience. It was a tiered part of the project development. Often it's not easy to find enthusiastic team members from the public. Can you hear me?
I'm afraid that there's a bit of feedback, I'm afraid.
Edward, if you're...
Is it better now?
No, Edward, if you're on Zoom and feed loop, if you could just close feed loop for now and just talk through the Zoom link, please.
Hi, can you hear me?
There's a lot of echo.
Okay, so I will hold off. I'm very grateful to the public advisors working on this project.
So it sounds like you found that the working with the public advisors really helpful and valuable experience, which is
absolutely. So very straightforward, very positive feedback, very positive in a way, constructive, and sort of moving in the right direction, helping to shape the project very easy to work with, very efficient. I'm very glad.
Great. So they're running a very tight ship. You're running a tight ship there, Hilary. Was any anything you want to add to that?
Just that this now sounds like a mutual admiration society, but I actually have used Edward as an example of his projects, an example of good practice in keeping a true collaborative approach with public advisors, and of making sure that we're up to date with everything that's going on, and giving us the option of having that any feedbacks and reports or whatever in formats that are useful to us and useful for us to contribute. And finally, I just want to reiterate what I said in that video, because it really has felt like I've got a voice for my mum and my auntie.
That's great.
That's it.
That means a lot, clearly. Okay, I'm scanning for hands up and things in the chat. I don't see any. So I'm going to move us on now to hopefully a bit of a show and tell and discussion around integration and continuity of care. I'm just going to share a couple of slides just to give a bit more context, and then open the floor. Assuming I can master Zoom. I've lost. There we go. Let's try that. We've been wrestling with how we should approach problems in the integration and continuity of care, and it's over a year ago now that we identified this as an area that everyone was really interested in. I think one of the reasons that we're struggling a bit is it's just so massive. It cuts across the whole of healthcare, and we have limited resources. So we're going to need to make some decisions about what are the things that we want to do, and clearly what the partners and the public want to do is paramount here. And of course, what you've got on the slide here is a clinician's view of the world, and obviously my view of the world is not necessarily the right or the only view of the world, but it does have some resonance with our public advisor co-leads. So just really trying to highlight the complexity of healthcare, particularly when people have multiple health problems, and in addition, their access to or the delivery of healthcare is adversely impacted by their experience of health inequalities. So try to identify we've got a person in the centre here that's got complexity. Maybe they've got multiple health conditions. Maybe they're something to do with where they live, or the contributors to health inequalities and inequity that have been a thread through this meeting. And of course, those individuals maybe are likely to be interacting with primary care. They may well be interacting with a number of secondary care services, interacting with social care, emergency services, and charities, or VCFSE, which is an acronym that I've learned during the course of today. Sorry if I'm a bit behind the times, but that's a new acronym for me today. And clearly, what people are saying is that these services don't talk to each other. Things aren't integrated. So information isn't shared around, so people are seen in primary care or secondary care service, and individuals don't have information from the other services. People are frustrated that they're seeing multiple different clinicians or people advising about their care. So we've got significant problems with kind of integration, and Steph very nicely highlighted that in addition to the kind of complexity of the service, there are huge challenges for people to access them. They don't necessarily know who to access to help them navigate through the services, or there may be specific problems that they have which prevent them from accessing care. And Steph obviously has highlighted the people with addiction as examples. And in terms of just thinking about where we start, clearly we need to find a sweet spot of the kind of the problems that everyone is interested in, public services, and do we have some research now how to actually address the problems that we're going to highlight. We could look at it in another way, think, well, we want problems and solutions, and we want to implement something and then evaluate it and enter this virtual circle. Maybe it's a plan, do, study, act kind of cycle that we can set up as we try to improve the way that we deliver and evaluate our services. I think we've also had a bit of trouble working out, you know, what's the footprint, what's the scale? Do we want to do something very local? Do we want to do something regional? Do we want to be ambitious and do something at a kind of national, global stage? And certainly the ARC network provides an opportunity for doing something grand. But I think we probably need to start with something local and get a few ducks in a row. What I thought would be helpful is if we could have what I've glibly called kind of show and tell, and it'd be great to hear from people on the call really about service changes or service restructuring that they're aware of, where there's an attempt to try and improve the continuity and coordination of care, or their research projects that are being built or they're aware of, and what's their experience of co-production and so on. So I'm going to just stop sharing, having hopefully just provided a bit of context, and be just really helpful to hear any projects that people are aware of where there's an attempt to change services to improve coordination, integration, or research projects, and how things have been built up from the ground up.
Can I tap in, Tony? I think from a community perspective, I think it comes back to social prescribing in the respect of Macmillan link workers. I think dealing with patients with cancer, and I think the links that they don't have within that immediate community, they go out of their way to sort of try and make. So recently in our community, we have a Macmillan link worker. There was a lady from another community that didn't speak English, had a diagnosis of cancer, so she looked within the community to see if there was an interpreter that could just interpret in her own language the journey and support out there. And the links that we've got with the social prescribing networks within our community really worked hand in hand for this lady in signposting her to sort of community pantries, to other networks of social groups and things like that, just to sort of ease the journey of this cancer diagnosis, and also support for her children as well, which was really important. So it was about knowing the connections within a community that you're working within, because she works, this link worker sort of works in several practices, covers a wide area, and obviously several hundred patients. But knowing our community and the links that she had within, I think the connections within the communities of the networks that are there is really important, to be able to widen the networks, and also to be able to marry other communities with other communities in the networks that are there, which is really important.
Thanks, Steph. And I think, Carrie, you wanted to add to the conversation?
Yeah, sorry, Tony, I'm not able to raise my hand for some reason. Yeah, I'm just going to reflect on a project I'm working on at the moment with across 3 HEIs, so University of Liverpool, LGMU and Edge Hill, and that's around special educational needs and disabilities. It's an NIHR funded research project. But I think what the team have done that's been really important in terms of community involvement and engagement, but also considering about the integration of care and continuity of services, is think about the research project from a multi-professional perspective. So really trying to think about it in terms of all the various complex layers. And I think certainly from right back to when they devised, when they put the application form together, they started the community involvement and engagement at that point, rather than once they received funding, which I thought was quite a unique way of going about research funding, which I think has really helped in terms of the project. But I suppose what also struck me when I was looking at your slides earlier, Tony, was maybe there's something else as well about linking in with policymakers, because it's great to have stakeholder involvement and research that's answering specific questions for our population. But if we can't influence policy, even if it's local policy, then it can often make it difficult to try and implement some of those research findings. And particularly we've found this with the SEND project. So what we've tried to do within this is to engage local authorities, schools as much as possible, but ensuring that throughout it's the child's voice is central to that. So we've done things like going out to schools, asking children to write on a postcard what they would, if they sent a postcard to Boris Johnson, what would be on that postcard. So you can imagine there were some quite interesting responses there. But the team have worked tirelessly really to try and engage with as many parts of the community as possible, and in really creative ways. So I'd certainly, when the report findings are completed, I'd certainly like to share that with this group, because I think what would be nice following on from that is to think about, well, what do we do next? So we've got this report and that's fantastic, but how do we actually ensure and hold some of those policymakers to account in terms of implementing some of these research findings? So if we can link up with ARC in any way around that piece of work, I'd be really happy to do that.
Thanks, Karen. I think integrating or working closely with the integrated care systems or integrated care boards is going to be really critical. I get the feeling that they're still finding their feet in some ways, but yeah, piggybacking onto their programs of work or working with them is clearly going to be vital.
I think just on the children and young people's ICS, that their groups now are formed in some respects, and they've got 4 priority themes, which I don't know if you've discussed or you want me to. So it's obesity, learning disabilities, mental health and respiratory. And I get the impression that they are very much aware of the fact that they need evidence-informed interventions, but that they also need to be thinking about the evaluation of those interventions as well. So I think we're probably pushing at an open door in some respects, but it's about getting the processes in place.
Yeah, and it's about making sure that we're not working in silos, isn't it? Kind of linking up and working across the various bits that we have funded. And I think that's really important for ARC to make sure that we're well integrated into what else is going on in our local systems. Thanks, thanks, Kerry. And Richa Gupta, you put something in the chat about Nest at Home. Is that something you'd like to raise verbally to those?
Hi, yeah, it's Richa Gupta. I'm a neonatal consultant up in Lancashire, and the project that we've been doing for the last few years, kind of following on from Clark, it does, I think, have an approach which kind of incorporates a variety of stakeholders. So initially the project came from the specialist commissioners to help us to encourage reducing the length of stay of babies on neonatal units to get them home earlier. As part of that, with the Clark, we embarked on a Hyatt with a parent advisor who was a previous user of a neonatal unit, which gave us some really good insight into some of the parental views through focus groups and questionnaires on what their perspectives were of the discharge process. The next stage that we're doing of the Nest at Home with ARC is now to pull together through the ODN, so the Northwest Neonatal Operational Development Unit delivery network, sorry, has got parent advisory groups. So we're going to use their advice to get a co-production for a sort of a questionnaire and survey evaluating outreach services over the last 12 to 18 months during the pandemic, when there wasn't access so easily to universal services in the community for these parents going home with with babies with complex needs of variety of levels, and these parents quite often from deprived and disadvantaged backgrounds. Because obviously a lot of the people working in the community were redeployed or working from home, which if you're a health visitor, it's not very easy to make visits, and we've had concerns around the safeguarding issues over the last 12 to 18 months. And as we've already discussed on this forum and others, around the fact that actually everybody's not as easily digitally connected. So our next stage of the Nest at Home sort of co-production will be to design some questionnaires, again, focus groups around the things that worked well for families last year with outreach services, where there were deficits and gaps, what they'd like to see that would help them make the services fit for purpose. And I think through George at Liverpool, we've managed to get some funding together from the Benefits for Patients Network, I think. So we're going to start obviously locally in the Northwest and in Lancashire, but potentially we might be able to work up a protocol that can be universally applied to scope across the country, because this is, I think, a generic and universal problem. But you know, our experience from the Clark is helping to inform our process to build on that.
That's great to hear. And yeah, Victoria, you've just put something in the chat about the Beneficial Changes Network.
Yeah, sorry, that was for Risha when she couldn't think of what the name was called for the funding.
Yeah, yes, of course.
So it's just so everyone's aware of that, because we'll probably be hearing a lot more about it soon. So
okay, cool. I wonder if we've got Greg Lipp on the meeting. Greg, whether you want to just give a kind of a cardiovascular perspective and sort of stuff that's going on in the Liverpool Cardiovascular Centre that's relevant to the integration and coordination of care, if you're online. Sounds like Greg might not be plugged in at the moment. And I wonder whether there's a kind of a big data element to this, just to raise. I see we've got Pete Dixon, and I don't know whether Ollie's on the call as well, but there was in the CHI meeting earlier highlighting the opportunities for using data for investigating kind of health inequalities, but strikes me that we've got a massive opportunity as data sets are being linked and coming together to map out what are some of the significant health inequalities and problems with access to care. I don't know whether Pete or Ollie want to comment on the opportunities there.
Hi Tony, it's Sarah as well.
Oh, hi Sarah, hi. Sorry, I had a quick flick through the participants to work out who was here. It'd be great to hear from you.
Yes, so there is a big opportunity to get the health inequalities data, the data right, so we can look at health inequalities like Wes was saying. I guess the next dimension is when we've got that data correct, is that we need to make sure that it links together across social, education and different data sets. And I know one of a colleague down in London, Katie Harron, has looked at neonatal health and looking at the bias in data sets. So basically you get people who are, say, of different ethnicities missed out when you do that. So even if you get the data right in the first place, there's a potential to miss people off at the next stage when you link together across multiple data sets, which is when the real power comes from looking at if you've got education and health and social care all linked together. So it would be useful to make sure that we don't get some of those biases in the data, and yeah, just to make sure that we've got all our data sets lined up so that we can do some research and make sure that we're not introducing health inequalities inadvertently.
Yeah, that's very important. Thanks for that contribution, Sarah. Okay, does anybody else have any intelligence of what's going on elsewhere in the system that they'd want to add or highlight that we need to know about in terms of our attempts to improve the coordination and integration of care?
Tony, I've got one other thing, if it's okay to raise.
Yes, of course.
So we're currently working with the council on an early years portal that they're developing, which is essentially, as the title suggests, about collecting data across the life course, but particularly focusing on it the early years and seeing if we can integrate that data across different data sets, different organisations, different services. And they're linked in with System P. We're hoping that we could possibly develop a project around complex lives using that early years portal. But I know at the moment they're in the consultation phase about what the portal should look like. So I think it's important that ARC feed into that consultation process as much as possible as well. So I was going to have a chat with Jo Blair, through the life course theme, to see if she wants to have a look at. There's a template that he's currently working on, but I think it makes sense to link that up now rather than later on down the line.
Yeah, I don't think Jo's in this meeting issue. She was. I saw her in the participant list.
Yeah.
For the meeting, Alex. She might be.
I can find Jo. That's fine.
Cool. Right. So I think we've got 1 minute left. So we're about to be sucked into cyberspace. So I found that really helpful. I hope you did, and it was an opportunity to just get a flavour of what's going on, and starting off with a broader perspective of the kind of things that we want to do. From the point of view of integration and continuity of care, I think it's just important we really keep the conversation going until we've actually drilled down into the specific things that we want to lead from an ARC perspective, particularly as the integrated care systems or integrated care boards mature. So I'd like to thank you for this, for your participation in the meeting, and I will draw it to a close. Thank you.